Hello and welcome to today's episode of Community Connections, airing right here on OROMIA11. I am your host, Anna Orr. And as you can see, I have on my pink today because it is Breast Cancer Awareness Month. And I have with me the coordinator for the Breast Cancer Champion organization, as well as the Breast Cancer Education Association, Galen Richards. We're going to be talking about her lengthy career in the nursing field over the last 50 years, and we're going to talk about prevention, a little bit about data and statistical information that will be very relevant to you. This is going to be an episode you won't want to miss. Thank you for joining me on today's episode of Community Connections. Galen Richards, you are here on behalf of the Breast Cancer Education Association, as well as the Breast Cancer Champions. Welcome to the program.
Thank you, Anna, and thank you so much, and OROMIA11 for inviting me to join you in this community conversation.
Absolutely. Now today we are talking about breast cancer awareness and prevention, and to talk about the work that Breast Cancer Champions as well as the Breast Cancer Education Association is doing right here in the great state of Minnesota. Can you talk to me about your work as the Breast Cancer Champion Coordinator?
11 years ago, the idea came forward that we work in the known and trusted locations of the African American churches right here in the Twin Cities and beyond. It was a collaboration between the SAGE screening program, I worked for them at that time, American Cancer Society with my colleague Benita Robinson, the Stair Step Foundation, and clinical providers who could bring mobile mammography and also clinical support for women. We worked with 10 to 12 churches in those first 5 or 6 years and screened hundreds of women for breast cancer. Then in 2019, we were approached by Dr. David Haynes from the University of Minnesota. He is a professor there and works with the Masonic Cancer Center, and also Dr. Kelly Hughes from the SAGE program. Did we want to collaborate on a grant through SEARCH? That's a unit at the university that links a community principal investigator and a university principal investigator. And Ms. Robinson and I agreed. We were funded, and we were able to show that our work with the Breast Cancer Champions made a difference in the neighborhoods we were active in. The number of women of African heritage enrolled in the SAGE program as compared to the year before we became active. You know how scientists, we have to always statistically be significant, and we were. From that time, once that grant ended, the SAGE program actually funded our work, and now the Masonic Cancer Center does. I have 11 active champions. They represent East Africa, West Africa, and African Americans, and our work continues. Our outcomes have been outstanding.
Now, for people that may not be familiar with Breast Cancer Champions, can you talk to us about what that is? I'm familiar because I've done my homework, but I'm sure viewers are listening to this going, it sounds pretty cool, but talk to us about what they actually are.
It's very cool. These are community women who have come forward. They want to be seen as a resource, a guide, a support system, and a navigator for women of their community. They've gone through a very special training, and they then develop a work plan for their community. They know best where women gather, shop, worship, get with their families. And so they put together a work plan that says the kinds of activities they're going to do. They take out tailored materials, business cards. We're branded, so we're wearing our champion t-shirts and carrying our champion bags.
Right.
And women can come to them, call them, connect with them. And we work in kind of two different ways. We work at more formal events, like we have a community health fair coming up that we are planning and hosting. We support mammogram events done by Park Nicollet Mammo A Go-Go. But they also can go out informally to food shelves, grocery stores, churches in their neighborhood, organizations that are in their community, and drop off materials, connect, make new connections for us. And so amongst that work, I would say in the last 11 years, we have educated about 15,000 women, and we've probably screened, confirmed screening, maybe 1,000 or more.
Now, you have a very long history, 50 years in the world of nursing and doing this kind of work specifically. You are a doctor of nursing practice, you are a registered nurse, and you have a master's in public health. So you are not only someone who knows exactly what you're talking about on a regular level, but also from a medical standpoint, and watched the progression of this terrible disease affect people for the last 50 years.
What I've seen over time, I started as a hospital-based oncology nurse. And because of my motivation from my family and personal history, I had a chance to establish my hospital's breast program. Women were not getting screened. Women were presenting with late-stage diagnosis. And even in those early days, I worked with our African American community, our Spanish-speaking community, our Asian community, to bring mobile mammography to them and help them come to our center to be screened in a way that was respectful and thoughtful. What I see across time is we have had a tremendous reduction in death from breast cancer, but not in all communities. Women still are not aware of the benefit of regular screening, or they may have unique barriers that we must work together on trying to reduce or surmount. So again, on the screening side, more awareness, more availability, better screening, but then we get to what happens around the death rate with women of African heritage. Much higher than any other group for a lot of reasons that we may be able to understand and maybe we still need to explore. So a lot of things going on out there, and that's why I'm so very, very grateful of the work that the champions are doing and maybe someday replicating in other communities.
I think it's so important just to talk a little bit about the mission of this work. The mission with the Breast Cancer Education Association is this. It is to educate the community by providing support and information about breast cancer detection, diagnosis, treatment, and survivorship.
Yes, 23 years ago, Ann Harris was a nurse in the Alina system, and she took care of a woman, Lois Joseph, just diagnosed with breast cancer. They became friends. That happens. They clicked. Right. 4 months later, Ann was diagnosed with breast cancer. And they talked and they said, where is the information? Where is the support? How do we know this? How do we learn this? And Ann, as a nurse, was very educated, but she herself admits, I knew so little about breast cancer and what to anticipate and expect, that certainly there were others, women, families, communities, that would be in the same place. From that, the Breast Cancer Education Association was born. We just had our 23rd annual conference, and we keep going. It's better, but we've really made outreach and inclusion a strategic pillar. We've also made continuing to support research findings and disseminate them out across detection, treatment, and now survivorship, which I think is a phase of the journey. There's been some looking at that, like the African American Breast Cancer Alliance. Mm-hmm. They really involve themselves in the quality of survivorship for women. the Gaps Project, looking again. But we have so much still to do. So I've just got to, the joke is I'll never retire because there's too much to do.
Now, you just shared that you all just completed the conference.
Mm-hmm.
What was some of the focus of that conference, but also specifically around the panel that you had recently?
The panel, it was really looking at how we support the journey of African American women. And we had experts and survivors, and we made it very interactive. I moderated the panel, so I wanted everyone in the room to join in the conversation. And it was really beautiful because we had several women who were just so newly diagnosed, including an immigrant African woman. We had others further along on the journey. And people stood up and talked about Dr. Ora Hoax. If you know Dr. Hoax, she talked about the historical trauma experienced by African American women and how it still impacts on seeking health care, accessing health care, and may still be part of the mix that we feel when we walk into an institution where perhaps thoughtfulness and respect may be lacking. We had other women rise and say what resources had been helpful. On the panel, I had Dr. Rick Zira from Hennepin Healthcare. And over the years, I've gotten to know Rick rather well. And he really embraces all worldviews. And a woman diagnosed with breast cancer is his client forever.
Okay.
And so we talked about that. We also had Dr. Mark Migliore with us that day, and he added to the conversation. So there were women, their family members, health professionals, all joining in a really vibrant conversation about how we can change it. Some things we came away from is, how do we let everyone know about the resources we have? How do we develop new resources? Do we need to go back to a program I was involved in called Sister to Sister, where you actually go with a woman getting her chemo for the first time or going with her for those first appointments when so much information is coming to her? How do we explore the survivorship piece? How do we understand the unique needs of each community? Because it's going to vary. Right now, Riona Berry, who's the executive director for ABCA, is involved in a study looking at perceptions around survivorship for African American women. I will be so excited to hear what comes out of that. But we need that in every community. Otherwise, people screened, some will go on, some will have treatment, and then what? Do they fall off the cliff? I don't want that to happen. I want that support and resources there for each person with cancer.
Now, we know that there are plenty of times where systemic racism affects healthcare outcomes as well as, like you said, people receiving resources, treatment. How are you all able to navigate at the BCEA this great divide where people are, like you said, starting to fall off, not only during treatment, but sometimes heading into survivorship, and then they're looking as if there's nowhere for them to go?
One small thing that BCEA did a few years back is write a racism and inclusion impact statement with action steps. And I know that other organizations are taking those steps too. In fact, I just sent that over to another organization here in town to see what we did. And because I was involved in the writing of that, there always has to be action steps. The other places where I think we're beginning to see traction is the Breast Cancer Gaps Project. Also, the policy work being done by the Minnesota Cancer Alliance, which has an overarching aim and theme of equity across all cancer care. There are other, things happening, and we just have to keep pushing the needle.
Now, you talked a little bit about some of the research side of things, so we're going to shift and just talk a little bit more statistically about what the data is saying and how this is affecting populations of African American women as well as women of African descent, period. Because like you said, we're looking at these numbers and it's affecting us at a larger rate than it is other women of color and or our Caucasian counterparts.
It's interesting. I want to just talk about data for just a minute. When we look at screening, we see that an incidence of new cases, it's non-Hispanic white women with a higher incidence, and that may be a reflection of a higher screening rate because of access, insurance coverage, availability, awareness. So nationally and here in Minnesota, Black women and white women are screening at a fairly similar rate. But what we see is women of African heritage dying of breast cancer at 40 to 41% higher, and that's national and right here in Minnesota. A higher percentage present at a later stage. They may or may not be offered the same, depending on where they're seen. Yeah, it makes my blood boil. I'm just going to put that right in here. All the years that I have done this work, and still these inequities exist. And I have to ask myself, why? Why is that? So we must not only advocate for ourselves, we must demand excellent care for all of us, all women. Excellent care. And I've heard enough stories about a woman going in and the provider not being very impressed with the change in the breast. Like, oh, come back in 6 months, or oh, it's nothing, or that's when you go and you get another provider. When you have a new diagnosis, I encourage second opinions. We have 2 National Cancer Institute comprehensive cancer centers in this state, the University and Mayo. There are many other good systems. Right. Don't take me wrong. Many of them. But think about a second opinion. If everything matches, isn't that a wonderful feeling of like, okay, we're ready to make a plan now? But, you may want to see clinical trials. That's something else that is not offered up front to someone with a cancer diagnosis, and it should be. And we have multiple sites that have clinical trials going on. And wonderful nurses, you can just call and speak to a human being and find out what's available here in Minnesota.
I think it's very important to not only know that we have those amazing systems here within our state, but also realize the need for such. If it's right here, we have 2 of the largest right here in our very own backyard, that there's no reason why women are not able to get the services that we need.
I have to agree with that. And when I look at overall survival, nationally and here in Minnesota, overall survival is very high for localized breast cancer, very early breast cancer. It really drops when the breast cancer is regional or if it's widely spread through metastasis. So the intent is we find it in every community when it's so early, it's amenable to treatment and cure. Breast cancer swept my family away, and I don't want that for any other family. And that's what I'm going to be all about.
Can you talk a little bit more in depth about that? You found that you lost multiple family members, correct? From breast cancer.
Correct. I will. I'll share that story. I've just recently started to share it. It was found out really within the last decade. My family carries the BRCA mutation for breast and ovarian cancer. So we all have a favorite aunt. My auntie was Aunt June. She could fill a room with her spirit, and maybe with her size too. She was diagnosed at 35 and gone by the time she was 40. And a few years later, my mother taken, young. My grandmother, my cousins, everyone on that, not everyone, but almost a lot of the women on that side of the family. And I think when my aunt died, that set me on the path. I was already a diploma nurse. And then with my mother, that was it. I knew what I was going to do. I was going to make sure that others were aware, informed, even if I had to go to their house and pick them up and take them to the appointment. And I have done that. I have done that. And I think what brings me joy in my life is being in the community and talking with community women and helping them to know that the Breast Cancer Champions, BCEA, the other great organizations we have here, we are here to help, to support, to bring information, and really whatever else you might think that would be important along that journey, whether it's the screening journey all the way through survivorship.
Now, you spoke about how it affected the women in your family. And for many, because of seeing Susan G. Komen Foundation, or to see pink or the ribbons and things, or to see the numbers of what it's affecting in women, many people believe that this is only something that's affecting women and girls at a younger rate, and that's not the case. Can you speak to the cases of men that you've seen over the last 50 years of this work?
Yes, I can, and I just got new data yesterday. Women across their lifespan is about a 1 in 8 risk, and every decade of your life you have a little bit different level of risk. So by the time you're my age, it's 1 in 8. For men, it's 1 in about 1,100. And it's really thought that that higher risk in men is related to BRCA2 mutation.
Wow.
BRCA2. And again, just saw new genetic data at the conference last Saturday.
So this is very timely.
Very timely, very new. Also, gentlemen, if you're listening today, if you're listening in on us, that BRCA2 mutation, you do have to be tested, but not only breast, but seems to be implicated in prostate cancer, which is new information to me. So I will be including that in my community education, because I like to talk to the gentlemen too when I'm out in community.
What has been the feedback from men when you're having this conversation in the community with them about breast cancer and the likelihood of it affecting them?
We have a new educational piece from ABCA on men and breast cancer. It flies off my table. They don't know much about it. They're interested in it. They ask great questions. We talk about the most common symptom a man might have, which is a lump under the nipple, so easy, to check that from time to time. And they're really glad that this information is becoming available. Mm-hmm. I love those conversations with the gentlemen. They also, like it that we can talk about the other kinds of screenings that men need to have.
Can you talk a little bit more about that, seeing as it is Breast Cancer Awareness Month, but we always want to continuously talk about cancer and the prevalence of it in the community at large, because it is still one of the leading killers of people.
Colon cancer and prostate cancer are two cancers that have a higher rate in the African American community. And it may be related to the risk factors of diet, physical activity, a lot of things. Nothing is one factor. Everything is always a bunch of factors that come together. But men seem to be very open and very glad to hear, like prostate cancer. They should talk with their doctor about at age 45. But it's a blood test. It's a blood test. It's not any other kind of thing. And that can be determined. A man with his provider can make an informed decision about how often is it important, what are the risk factors. Colon cancer screening, there's a number of ways that someone can screen. And depending on family history and risk factors, you make a decision that is okay for you. So the gentlemen are usually quite happy that there's a couple of options for take-home tests in the privacy of your home, but for some, colonoscopy and screening, colon cancer screening, more and more, we know that the test that gets done is the good test. And the sensitivity, the ability to find those changes are about the same across all three of the current colon cancer options.
Now, you said something a little earlier about the BRCA mutation. Can you talk about that and kind of explain that to viewers?
I can certainly try. We know that about 30 years ago, the BRCA mutation was first discovered. It was really one of the first of the genetic mutations. Cancer is really in the genes. You have damage to the DNA from either internal factors or external, like think about smoking, or think about exposure to asbestos. Those are a couple of examples of external. Internal is our genetic makeup, what we inherit from our family, genes come down. And there can be changes, internal, external, or just because that's how you're born, that may have the ability, when the cells replicate, to have that change passed on from that 1 cell to 2 cells, 2 cells to 4 cells. Under the right circumstances, in the right environment, it's complicated because our body kind of like can fix a lot of things. Right. But that could develop into a change that could become serious at a later date. So these changes can work in sequence or together. And what's being discovered, I can't even keep up on all the genetic mutations that have been discovered. Ones that are real clear around breast cancer, but others that when they're working normally, they stop things entering the cell that might cause a change. They act like a brake. This is like my favorite mutation. When it's mutated, it's like, come on in, we're having a party in this cell. So the world of genetic study is just expanding exponentially. And now testing for genetic mutations has come down to a reasonable rate. The one company that was doing this testing lost their patent some years ago. Okay. So other companies are doing it, and it can be a very good way if someone is concerned. They should talk with their provider. They're often referred to a genetic counselor, and then the genetic counselor will make some recommendations about testing.
Okay. I appreciate that information because I think sometimes there are terminology that's used and we're going, this is going way over our heads, specifically people that are not of the medical field or who haven't been doing this work as long as you have. So I always want to take small breaks to try and give people the information in small bites. You've spoken about the program where you all had people going with people that were receiving their first treatments or going to hear diagnosis information with them, because we know that throughout this process it can be a very solitary experience and you begin to think, this is only happening to me. Or yes, you hear the numbers of who this is affecting, but there aren't a lot of people consistently talking about what this experience is like for them. Talk to me about the work of the BCEA and connecting with women in the African American community as well as the East African population and connecting the dots for them.
Well, part of what BCA does is they support the Breast Cancer Champion Project. They have a number of roles in that, and my champions really represent East African, West African, and African American. We have developed breast cancer infographics in Somali, Hmong, Spanish, and English, and they are widely used because, they're available.
Right.
They've gone through a community review process. We're pretty confident that they are correct and proper and respectful, and they reflect, current thinking. We also are interested in other ways we can utilize formats that are perhaps a better way, like through videos and oral. And so we have a lot of partners we discuss these things with, including Masonic Cancer Center and Dr. Haynes. He and I and others continue to search for this because there may be a better way to reach than a piece of paper. Mm-hmm. I'm old. I like paper. But for others, maybe it's that video. Maybe it's that in-person presentation. Maybe it's a different way. So BCA is very supportive of the work our outreach and inclusion group does. And we pretty much will go anywhere, anytime. And we're happy to be there.
Now, you've talked about your work in the community and partnering. How has ethnic media and or social media been used to connect with people about disseminating this information about breast cancer?
Over time, we've done a lot of different things. I've been on Hmong radio. I have been interviewed by Oromo TV in the past, mm-hmm. and just as recently as last February at the big City of Minneapolis Community Connections Conference. Yep. And I got asked about materials in Oromo, I'll tell you. And I was able to actually talk a little bit about that, which that's the next place we're going, if I have anything to say about it. I've also been on, the SAGE program uses Spanish language media, mm-hmm. a lot. And I'm now working with ACER in Mankato, and we're developing more engagement, more ways to reach women down in that rural area, because rural women, whatever community they're from, mm-hmm. are not getting screened.
And why do you think that is?
Access, and I'll just talk about here in Minnesota, where I know maybe the most. There's access, so that's availability. Mm-hmm. They may have to travel a long distance to be screened or to get treatment. The rate of insured people in rural areas in Minnesota is much less than in the metro. They also, let's say they have to drive 25 miles and the car is old and it's snowing that day, and then their daughter calls and says, "Can you take care of the grandkids, Mom? I've got to work." Also, work schedules. Are the clinics open when people can get to them? We even have that issue here in the Twin Cities. If you can't get time off of work, you need to have your care at a different time, mm-hmm. evening or Saturday. Sometimes you really have to look to find a clinic that meets your needs, that is available when you are available. So all those things come together.
Now, you have spoken a bit about the health fair coming up. Can you provide viewers with some of the information around the health fair? Talk to us about what people can expect on the day of the health fair, as well as some of the people that may be joining you that day.
Ooh. Well, on November 9th, the Breast Cancer Champions are once again planning and hosting a community health fair and mammogram day. And that will be from 9 until 4. It will be at the Church of the Epiphany at 4900 Nathan Lane North in Plymouth. It is our 3rd annual. 3 congregations share this building.
Wow.
And this really draws many West Africans, but of course all are welcome. I'm starting to line up speakers, so we're going to have Keith Allen talking about prostate cancer in men. I have the Sickle Cell Foundation speaking. I've got fun stuff happening. Mary Kay Cosmetics is coming to do hand pampering. And we'll have many partners there to, M Health Fairview is going to do vaccination. So we'll have many partners there that will share their resources, their information. There'll be refreshments, there'll be door prizes, there'll be a class on hands-only CPR training from Mother Carolyn Best.
Okay.
So it's really a fun day. And for mammograms, I apologize, I don't have, one of our champions is taking those calls, but people could even contact me and I can route it through, and we do have available appointments.
So people would be able to get on-site mammograms at the health.
Correct. We do like them registered in advance because we want to utilize the resource fully. So we have 31 appointment slots. I'm not sure quite how many are filled at this moment.
Okay.
But we have availability, and we have a number of churches coming together to partner with us to recruit women to come on in. I'm hoping the ladies will be cooking in the kitchen, making up something good for our lunch. And we really have a good time.
Now, outside of the on-site work and the the breast cancer champions joining you guys, you also are having some community sponsors, partners that are going to be there as well with you all. What had the partnerships meant to the work of the BCEA?
I think it really, we share a vision of a cancer-free future. And one of our partners, the Masonic Cancer Center, is having a conference on November 2nd at UROC.
Okay.
From about 8:30 to 3:30. And they have secured the Park Nicollet mammogram van. So Ms. Robinson and I are helping with that too. It is a free conference. There's going to be listening sessions, collecting the community voice, resources, screenings. So that's another piece. And our partnerships, when I think about, is there a gentleman out there who's caring for his partner with breast cancer, and he'd really like to talk with other men about it? That's the organization Jack's Caregiver.
Okay.
They are fantastic. And of course that organization arose because their director lost his wife to a cancer that was diagnosed very late. We'll have Masonic there, Masonic Cancer Center. I'm hoping to have the Minnesota Cancer Clinical Trial Network there to help people become more aware and comfortable with the concept of a clinical trial, what it is, what it aims to do. We also have, a number, Gilda's Club, ABCA, everyone I can think of. I think I have 40 organizations on my list. And I invite everyone. We may be cozy, but we will have a wonderful day in community helping people to understand. And I also looked at to bring in someone who works around wills and estate planning, financial planning. I like those resources in too. Housing, if we can have one join us, a housing resource, because that can be an issue for folks. Plus we invite usually Neighborhood Health Source Clinic, North Point Health and Wellness Clinic, because we want our clinic partners to be there too.
Absolutely. You spoke about UROC being the site for the November 2nd event. Can you please provide people with the address for UROC if they are closer to that location on November 2nd than they will be for the health fair taking place?
Yes. Now, I always just say it's at, off of Plymouth and Penn.
Right.
And, that's where the van will be. And again, I think we would like women, we want people to attend the conference, but we would like women to maybe pre-register. We want to, again, utilize the resource fully, but I believe there may even be opportunity for walk-up that day.
Okay.
Park Nicollet is being quite flexible with us, they're a great partner.
Okay, so the location of UROC is 2001 Plymouth Avenue North, Minneapolis 55411. If you are in the area on November 2nd and want to attend that event and may need to stop by and get a mammogram if you haven't already this year, be sure to take care of that on that day. Now, shifting gears just a little bit, can you talk to me about you all's work on social media and sharing the work of breast cancer champions as well as the Breast Cancer Education Association?
BCEA, our website, and you will find Facebook there also, is info@breastcancereducation.org. That's really all you need to know for them. For champions, we only have Facebook, and you can find us by doing Breast Cancer Champions, and there we will be. If you have other questions about the champions, you'll reach out directly to me. And my email, gaylinrichards76@gmail.com.
Thank you so much for that information. I know that you said you enjoy paper, but there are so many who are using their phones every day, scrolling on different things, finding links, getting resources that way. And so I want to make sure that we're giving people all the information to stay connected to the amazing work you guys are doing. Now, we want to talk about prevention. How often should women and men be giving themselves mammograms, receiving their yearlies? May say to themselves, hey, I have a lump here, not on my breast, but maybe in my armpit or higher up, or I'm experiencing some symptoms of something. I don't know what it is, but I'm scared, and I need to start paying attention to this more and more. Can you talk to me about how often, as well as how soon, should you start doing these things regularly?
For a woman at average risk, and honestly, I don't know what that means, really. We're women. But the national organizations say start at 40. If you, of course, have any concern at all, you go in and you're seen. Most concerns will end up not being serious, but you need to go in and just have it checked out. But again, back to the mammogram screening guideline. We can ask for a mammogram every year. The current U.S. Preventive Services Task Force says every 1 to 2. So one every year is fine. Don't go longer than 2 years. We endorse yearly. Remember when I talked about that we've got a great survival rate if breast cancer is found early? A mammogram can find something that's like grains of sand, especially 3D mammography. You'll continue to screen up to age 75, and then you'll have a discussion with your provider. If you're still feeling healthy, doing well, no comorbidities that might be, of more concern at that period of time, you just continue to screen. And I learned that lesson. I took care of a woman. She wore higher heels than I ever thought of wearing. She was getting her radiation therapy. She was 80, getting radiation therapy because she had chosen a breast-sparing approach.
And can you talk about what that is?
She had a tumor, and she could have chosen to have the entire breast removed, but she chose option, which the survival's just the same, of just having the tumor removed, followed by 6 weeks of Monday through Friday radiation treatment. And she was my client, and she said, yeah, I chose breast-sparing because I'm still dating. And she was going to go right back, which you do after primary treatment is over. You go right back to regular screening. And that really like made me really think about this, that as long as you're healthy and feeling good, you continue to screen. And it's your choice if you want a mammogram every year. Federal law says insurance will cover an annual mammogram.
I think that's very important. And then talking about the ability to do a home check, like we spoke about for the men. I know that for some people culturally, they're saying, I don't want to have a mammogram. You know, I don't want to go in. It's uncomfortable, or I don't think I'm doing it right when I do it at home. What do you say to people that may be experiencing that?
I do talk to women about self-awareness. We need to know our own anatomy. But I really want to talk with that woman to find out what her concerns or questions might be about mammography, so we can help her be comfortable. And knowing the latest technology is, you know, it's a moment. It's very different from when I got my first mammogram at age 35.
Okay.
Because that's really the best tool we have right now. But I do want women to know that the message is know your own anatomy. We know ourselves best. We have to be our own advocate. So check yourself monthly in the shower or lying down. And for the gentleman out there, you know, you could just run your hands over your chest. And if there was something that you found there, and it can be in the breast area or up in the underarm area. Our breast tissue extends all the way up to our collarbone. Be aware of yourself. If there's a change, seek care. If you need someone to help you find a clinic or encourage you, or like I said, I've taken women, we are there either through one of the champions, they'll do that work, ABCA, we do that work. We are there to help women and men be aware and taken care of.
Now talk to me about the study that you all did with the University of Minnesota about breast cancer and some of the numbers you all found out doing this work.
Well, what we found, again, this was when the champions moved from its original frame of Sisters Standing Up to Breast Cancer, that's how we started, into receiving funding to study the impact of the champions. Dr. Haynes, one of his tools is geomapping. So he had done some geomapping of the metro area where women were not getting screened, particularly women of African heritage. And over that, we did this thing like where we had been working as champions and saw those areas that were aligned. So the study went on looking at, did our activity in these areas result in more women of African heritage being enrolled in the SAGE program or being screened? Mm-hmm. We could, we tracked it all. And in that short 15 months, I mean, my gosh, off the top of my head, I don't exactly remember our number, but they were outstanding. Mm-hmm. I think it took everyone by surprise what we could do. And I did have a full team of 12 at that time. And we like this work. We like being out. And we screened many, many women. And so the statistical analysis showed that in that 15 months, we increased significantly the number of women from the control period, which was the 15 months prior. And I just always, and we're published now.
Congratulations.
And you know that the scientists always want to have it proven
Right.
about what we do. So we were published just last year. So
Okay.
that's rather new to us.
Right.
And our work continues. And again, where else are we needed? I was introduced to a woman yesterday. Centricare in the St. Cloud area has taken a great interest in the Champion model. Could it be replicated there, where there's a large East African community that I've done some work with? Is it amenable to replication in other communities, like rural Spanish-speaking women? That's yet to be seen, but there's certainly interest. And maybe this peer-to-peer model, and it's proven, the peer-to-peer model has been used globally in Africa, in Asia, around heart disease, around diabetes, around cancer. Here in this country, a lot of work was done in California, in the Spanish-speaking community, around breast cancer screening. So I think this model works. Women of the community who look like the community members being a resource, a guide, a navigator, a support, a friend.
I think that's what makes the BCEA so unique. You often see the race for a cure. You see pictures, you see them out in the community, and they don't always reflect the community. And so to know that you all at the BCEA have breast cancer champions that really reflect the communities in which you serve is very poignant and very relevant. And we know that representation matters across the board. Specifically, though, in healthcare, it's so necessary to take such a daunting experience and go, I have someone from my community, someone that's of my culture, not only able to speak my language, but to also translate some of this very wordy, sometimes, information to me in a way that I can not only gain this knowledge, but then I can start implementing this knowledge and advocating for ourselves.
I think that you are correct in that BCA has put outreach and inclusion as in the forefront as a strategic pillar of the organization. The champions are also deeply involved in general outreach for BCA. So last week we were in the Hmong community. We tabled at the Telemundo Health Fair. It allows people to see the champions at work, the model that then they take back to their organization and say, could this work here? And also just how good it is to ignite a person's interest in being screened.
I think that's very important. Very important. Lastly, I just want you to look directly into this camera and give the community at large a call to action around getting screened, but also reaching out to you all about your work in trying to close the gap on breast cancer in the community.
It will take all of us to do this work. We've made such great strides, but not in every community. Please talk with your family. That's your mothers, your sisters, your aunties, your cousins, your brothers, your nieces, your nephews, your faith community, to be that spark to the next person about, hey, we can do this. This is important. Let's all go together as a group, and then afterwards we'll go out and find something fun to do. We can do that. And if you need help with materials or a presence or a presentation, you are more than welcome to reach out to me. And out in community, I'm known as Dr. Gay.
Thank you so much for
You're so
joining me
very
today
welcome.
on this episode of Community Connections and sharing with our viewers the work of the Breast Cancer Education Association and the work of the amazing breast cancer champions.
Thank you.
Sadly, that is all the time that we have for this episode of Community Connections, and I hope that something shared today by Dr. Gay and the resources she provided has given you the nudge that you need to make sure that you get yourself and those in your network checked for breast cancer. Do the screenings, find out early so that you can start to shrink the number around cancer, breast cancer deaths in our community at large. As always, I am your host, Anna Orr, and this has been a wonderful episode of Community Connections airing right here on OROMIA11. I look forward to connecting again with you soon.